Good evening, ladies and gentlemen, my distinguished panelists, and all my viewers. I'm Dr. Nishant Sharma, and I welcome you back to the second episode of this virtual discussion where we talk about lung cancer in India. This video series is a joint initiative by Voice of Healthcare and Pfizer, where we talk about the different scopes, the different improvements, the different treatment protocols about lung cancer in India. So, without further ado, allow me to welcome my esteemed panelists. We have Dr. Sushma Agarwal, Professor, Department of Radiology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. Good evening, Dr. Sushma. Thank you for joining.
Thank you for the invite.
Yes. We have Dr. Somnath Roy, Consultant Medical Oncologist, Tata Medical Center, Kolkata. Good evening, Dr. Roy. Thank you for joining.
Good evening. Thank you.
And we have Dr. Bhushan, Nemade, Radiation Oncologist from Navsanjeevani, Sankalp Hospital, Nashik. Good evening, Dr. Bhushan. Thank you for joining.
Yeah, good evening.
Yes. So as we know that November is Lung Cancer Awareness Month, and hence we are organizing one such public health awareness initiative in association with Pfizer. Allow me to set the particular introduction to this conversation. Dr. Sushma, my first question will be for you. What is lung cancer, and for the layman, how does it present with the symptoms? And please set the conversational tone of this particular discussion, please.
Nishant, lung cancer is the second commonest cancer in men in India and is the commonest cause of cancer mortality, death due to cancer, even though being the second commonest. So, lung cancer, as the name suggests, it is cancer of the lungs. And sadly enough, it presents in the last stage in 90% patients in our country. And this is basically because the patients go to the private practitioners and empirically they are started on anti-tubercular treatment, which goes on for 3 months. And this 3 month is very vital because it changes the stage of the patients from at least a mid stage to a later stage. And later stage means last stage where the disease is not curable. Whatever we do, we can only prolong the life by a few years, which we are going to discuss in the session today. But cure is not possible in last stage. So this is the most important warning signal which I want to spread as a message for the viewers today.
Right. Thank you, Dr. Sushma, for very, very wonderfully explaining the introduction. Dr. Bhushan, building on the conversation with Dr. Sushma, please tell our audience about the common signs and symptoms and the clinical presentations that we see with lung cancer. And you maybe divide it as per the grades that Dr. Sushma had just mentioned. Please.
So, as Dr. Sushma rightly said, that majority of the patient get diagnosed very late stage, at least for lung cancer in India, and close to 90% are in diagnosis stage 4. So why we generally diagnose this patient in late stages? For a very basic reason, because the capacity of lung is too much. A very small growth in lung probably go asymptomatic. So patient can have a cancer in him without any symptoms also, at least for lung cancer. However, the commonest symptoms which are warning signs, and everybody should know that these symptoms are quite alarming. That is cough, which is lasting for more than 2 or 3 weeks. Hemoptysis, that is blood coming through your sputum. Weight loss, backache, breathlessness on exertion, cough, which is dry probably, and sometimes a neck node, which can be palpable. Neck node means a lump in neck. But as Dr. Sushma also rightly told, that we have to diagnose it early. The only thing is that you don't have to wait for symptoms to diagnose lung cancer. You have to do routine evaluation after a specific age, and if you are having any specific habits, you have to be very vigilant in diagnosing the cancer early. So that test can be as easy as doing a chest X-ray probably in 2 or 3 years. So these are the symptoms, and this is what the general public should do. If they are smoker, if they have a strong family history for that matter, they should check themselves after some particular age.
Right. Thank you, Dr. Bhushan, for that answer. Dr. Sushma, are you saying something?
Yeah. What I wanted to say is that it is the commonest cause of this cancer is smoking. And smokers usually have a smoker's lung, which could be existing before. So how will these patients come to know whether are they going to develop cancer or not, or have they started developing cancer? So basically, the nature of the cough changes in these patients who have already have a smoker's lung, and they start losing weight also. So this is very important. Another most important message for the viewers today, that those who already have a smoker's lung, which becomes bad during winters, a change in the pattern of cough should be a warning sign for the smokers out there.
Right.
The other
Thank
thing
you.
is that please don't start anti-tubercular treatment without the diagnosis of tuberculosis. If it is only the cough or the sputum is positive for tuberculosis, then only they should take anti-tubercular
Mhm.
treatment, take another opinion, and so before starting an anti-tubercular treatment, because then you will lose 3 months of your vital time.
Right.
Just to
Right.
add, Nishan, this TB,
Please.
as everyone see, we have to find a patient who directly come to us. Many of the patient, at least I think I can count 60 to 70% of the patient takes anti-tubercular treatment, and then they don't respond to, they develop with pleural effusion, they don't respond symptomatically.
Mhm.
Then they try to see the what could be the other causes of that pleural effusion or cough or whatever it is. So as
Mhm.
rightly pointed out, even if it is a tuberculosis, please document it. Get whatever documented test to confirm diagnosis. Three
Mhm.
sputums. There has to be TB. N number of tests. N number of there are criteria, RNTCP criteria to diagnose TB, and don't cut short that criteria. If someone is having TB, it has also to be diagnosed in a proper way, so
Right.
that we should not miss these 3 months. 3 months is quite long period for CLM. A stage 3 patient can become stage 4 in three
Right.
months in CLM. So we should not. This is called as late time. Late time is the initiation of first, and you diagnose it early. So we are losing this very important time. So if a smoker is there and he has some alteration in voice, alteration in cough, has to see the
Mhm.
doctor.
Right. Thank you. Thank you, Dr. Bhushan. Thank you, Dr. Sushma, for adding to the particular question. Dr. Somnath, my next question will be for you. I hope you can hear us.
Yeah, sure.
Yes. So, in continuation to what Dr. Bhushan and Dr. Sushma had just mentioned, I would want you to give some insights about how is the diagnosis made. Like we were talking about tuberculosis and we are talking about lung cancer. How does a clinician and for the general public, how is a diagnosis made where a patient is, for example, suffering from lung cancer? How does a clinician such as yourself reach that conclusion, please?
Yeah, so thank you for inviting me also, and the good question. Definitely, we have to look at the not only the radiological parameters, but also we have to look the clinical symptoms and signs. The quite similar symptoms between tuberculosis and lung cancer in terms of weight loss, in terms of drenching night sweats, and some hemoptysis, this kind of things. So we have to see the radiology as well as clinical parameters. But apart from these, in advanced non-small cell or whatever small cell lung cancer, they are usually presented with some another symptoms like rapid loss of weight, like anorexia, like any metastatic symptoms like
Mhm.
bone metastasis in bone pain or any other things, and recurrent laryngeal nerve palsy when there is a mediastinal encasement. This kind of thing, hoarseness of voice, sometimes some horner light of symptoms. These kind of things is more favor for the lung cancer rather than the tuberculosis. And we have to correlate with the clinical finding with the radiology as well as lab parameters. Usually you have to do the sputum with the alpha AFP, as well as sometimes gene expert, and the MG culture also can be done, and sputum culture for the tuberculosis. And it is usually done from the bronchoalveolar lavage or induced sputum, or from any biopsy specimen. So that is the interventional part, and we have to collaborate radiologically also the pleural effusion. If patient is bilateral pleural effusion,
Mhm.
we have to see the cytology, cell block, and again the what is the cytology report. Is it any reactive hyperplasia or any reactive malignancies is found? So these are the things, and the PET CT
Mhm.
scan if we do the suspected of lung cancer PET CT, would reveal the SUV uptake also. If in at metastasis, definitely SUV uptake is more rather than the tuberculosis. So that the parameter. So you have to judge patient in history, clinical examination, clinical findings, then radiology, and then lab-based parameters. So these are usually the distinguishing features between lung cancer versus tuberculosis. And not only tuberculosis, but also there is some non-specific, non-tubercular infections sometimes predominate in our populations, like histoplasmosis, like sarcoidosis, like granulomatous lymphadenitis, like Kimura-Kikuchi's disease. These kind of things is also happening in very rare incidences. So this should be kept in mind.
Right. Thank you, Dr. Somnath. Moving over to our first round of discussion now. Dr. Sushma, my first question will be for you. So, how has the landscape of lung cancer care evolved in India over the past decade, and what do you feel are the key developments that have contributed to improved patient outcomes as a clinician that you have seen, please?
Yeah, so when I started practice 20 years back, it was very disheartening to see that the last stage lung cancer patients had a median survival of 9 to 12 months. So, as the awareness about the mutations which are prevalent in lung cancer patients has come up, and the therapy against those mutations, the commonest being EGFR mutation, and it's so heartening to see that those very patients who could not survive more than a year are now easily surviving at least for 3 years. And once we put them on second line and third line, then at least for 3 to 5 years at the maximum. So this is one hope, a very positive change which has happened in the landscape of cancer, and there are likewise there are many more mutations which have also been found out, like ALK mutation, and these are then ALK cross fusion is there. So these are the commonest ones against whom the targeted therapy is widely available in our country.
Right. Thank you, Dr. Sushma. Dr. Bhushan, my next question will be for you in continuation to what Dr. Sushma just mentioned about targeted therapy and personalized medicine. My question to you is, what recent advances in personalized medicine and biomarker testing have significantly impacted the diagnosis and treatment of lung cancer? And I want your answer to be specifically for the Indian context, please.
Yeah. So it is itself is a quite a, what you can say, the quite a long question this is, but I'll try to summarize it. As
Please.
Dr. Sushma also rightly pointed out, few years back when we were doing our MDs and all the things, stage 4 lung cancer, we just tell them that if GC is not good, go back home, symptomatic treatment, palcare, that's it. And even if you treat, they were not long-term survivors. However, everything has changed. Probably from diagnosis, screening, patient awareness for cancer. More people are now aware about cancer, and more importantly, the ways where we can now divide lung cancer. Earlier in our MD days, there were only two types of lung cancer we were knowing. One is small cell lung cancer, another is non-small cell lung cancer. And all non-small cell lung cancer treatment is same. Small cell lung cancer treatment is different, but all groups is same. Okay. So, but now we realize that in some non-small cell lung cancer, there are few patients who are surviving longer, and there are few patients who do not respond. So, what could be the specific reason? In 2000, early 2000s, then first, as far as the genetic test is, or I should say the personalized marker which is being diagnosed, that is EGFR. That is the first marker which get diagnosed, and then people came to know that those patients who are light smoker or non-smoker, or those who have adenocarcinoma lung cancer, they are harboring one mutation that is called as EGFR mutation. And then after this discovery, there were new drugs which has come, those who are blocking these EGFR mutations. And then to everybody's surprise, these patients on tablet are started doing better as compared to the chemotherapy, which has some side effects. So then the research started, then the first generation, third generation, second generation, third generation of EGFR inhibitor came. And then we came to know that it's not only just EGFR which is mutated. There is EGFR, there is ALK, there is ROS, there is MET, there is PDL1, there is BRAF. and there is n number of other mutations. So close to 50 mutations are there which can occur in lung cancer. And few years back in 2005 2006 we were only knowing EGFR and we were only doing EGFR. But now even in India, forget about all other countries or Europe or for that matter the Western world, in India now there are n number of labs which are doing this test, and we can individualize patient whether this patient is any targeted drug negative or targeted mutation positive. So this is the development which has occurred in last 15 years, or I should say 15 or 20 years in India. So we have very dedicated lab. We have access to all kind of drugs in India now. Earlier there was only chemotherapy. Now we have access to all TKIs. Now just to tell you that now we can diagnose a cancer by a blood also. I know it is at a very primordial stage, but when tissue is not possible to get biopsy, like let's suppose you were seeing the mass in lung, but it is very difficult to get biopsy sometimes. So what should we do? PET shows uptake, we cannot biopsy, there is a very small lesion, we cannot biopsy. Can we diagnose it by some other way? Yes, there is liquid biopsy available. So this is all development. Liquid biopsy means you can diagnose a cancer by taking some 5 ml or 4 ml of blood. Okay, but this
Right.
is not a very standard. I should not say that the general public should not go and give their blood and tell everyone that doctor just check me that whether I am a cancer or not. But if you have a documented disease in lung which is cannot be biopsyable, you can diagnose a cancer even on a blood, and you can
Hmm.
even diagnose this mutation on blood. So that's what has been
Right.
changed in last 20 years. Okay, as far
Thank you.
even in India that has changed.
Hmm. Right. Thank you. Thank you, Dr. Bhushan, for that answer. Dr. Somnath, a very similar question to you, wanting to learn your insights. So, could you provide some insights into the changing prognosis of lung cancer patients in India from, let's say, 10 years ago to present day? We have heard Dr. Bhushan and Dr. Sushma's views on that. Uh, we would like to hear your views as well, please.
Yeah, I am also the same as Madam is told, and my previous panel mate. So that definitely it depends upon which mutation positive, because EGFR mutation sensitive, mutation positive, the lung cancer prognostically, even it is stage 4, it is drastically improved from the last few years. Is around 2 years, 3 years. If patient is high PD-L1 positive, like highly immunogenic tumor, and we can offer immunotherapy, it the survival goes beyond 5 years. We have done 5 years, 6 years survival data also. So that is the most important thing. And the apart from this, as my colleague is also already mentioned, there are lots of targetable actionable targets for the lung advanced NSCLC. There are like BRAF, like HER2, like ALK fusion, like ROS1, and mate amplification, mate exon 14 skipping mutation. All targets is there. Huh? And recently, the top 2 directed therapy is also coming. So these kind of things is going in the drastic change in the landscape. And prognostically, it was good biology when there is an we can identify a targetable mutation in this patient. But preferably, the main challenges is the doing broad-based NGS panels from the tissue or from the liquid specimen, whatever, because of the accessibility, because of the cost, and for the time, these kind of things. So these are the major challenges.
Thank you. Thank you. Thank you, Dr. Somnath, for adding to the question that I had put up with Dr. Sushma and Dr. Bhushan. Dr. Sushma,
So
my next question will be for
it
you.
is, yeah.
Yeah, yeah.
Hello.
So, moving over to the particular segment of personalized medicine and biomarker breakthroughs, could you explain the concept to the layman here who is our audience? What is biomarker testing and what is the pivotal role that it plays in guiding the treatment decisions that you take for lung cancer patients, please?
Yeah, so again, to elaborate on the example of EGFR mutations, there are three main types of mutation: exon 19, exon 21, and exon 20. So, out of these two, and these are routinely done nowadays. And how are we personalizing is that we know that the routine anti EGFR medications works well against 19 and 21, but it is 20 which causes problem, where these drugs, the first generation, are not so effective, and hence it is Pfizer which got one drug, dacomitinib, which works well in exon 20
Right. Dr. Sushma, you appear to have a weak internet connection right now. We
for
have, yeah, you're back.
1 year on that drug. So it was really heartening to see the response due to dacomitinib in that very patient. And
Mhm.
now coming to the other personalized, why is it called personalized? Because it is for that patient. If that one particular patient has a mutation in exon 20 or has a mutation in ALK, and so therefore we are giving them therapy directed towards that mutation. So this testing is called biomarker testing, and the therapy which is directed towards these tests is called personalized medicine. One thing which got left out somehow by us is that there's another important marker, that is PDL1, which tells us about the chances of efficacy of immunotherapy,
Right.
which is another drug which has changed the landscape of treatment in lung cancer. And so, this is a wonderful drug, but definitely costly. And this is also a form of personalized therapy.
Right. Thank you, Dr. Sushma, for elaborating on biomarker testing and personalized medicine. Dr. Bhushan, my next question will be for you. So, as Dr. Sushma just explained, what is biomarker testing? How does clinicians decide personalized medicine and personalized treatment approaches? My question to you will be: in your experience, please share some examples of cases where you feel that biomarker testing led to a personalized treatment approach and it also increased the improved outcomes that you saw for a patient in your clinical practice, please.
Yeah. Before just answering this question, I wanted to make one comment, very important comment. This is for general public actually. So, as you know, the cancer is actually your own cells, and your own cells, when they grow beyond your limit or beyond your control, we call it as the malignant growth. Okay. So why this biomarker has come into picture? That what leads that everybody is aging, but why only few patient is having cancer? Or everybody, probably majority, many people smoke, but why only few people lead to cancer? So the answer to it is that it all lies in your genes. Genes doesn't mean that the genes which you have inherited from your family or your mother. Genes means there is some genetic alteration occurring at your genetic level. Just to give you an example, we all are talking about EGFR. EGFR is a driver mutation. What is mean by driver mutation? There are two kind of mutation. Driver mutation, which is very important mutation. If it occurs in your normal cell, that normal cell, because of that mutation, can get converted into cancer cell. That is the mutation is called as driver mutation. However, there are some mutation which are called as passenger mutations. So passenger mutations are not directly related to causation of cancer. However, all these mutation, what does all these mutation do? It converts your normal cell to cancer cells. That is first thing they do. Second thing which important they do is that they make sure that this cancerous cell grow longer as compared to, or live longer as compared to your normal cell. So all these mutation which are responsible to it, if you can target that mutation, obviously your conversion to cancerous cell or your cell will get die if you target those, because that is the responsible reason, or that is the reason for you have to cancer.
Right.
So coming back to my own experience of personalized medicine, believe me, before probably 2010, I would never do, because that time EGFR was very costly. At that time, like very few access was there. So many of my patient empirically well started on chemotherapy without doing the personalization of that particular this thing. And if you really see, all these mutations are generally occur in non-small cell lung cancer, that is adenosine. There is one entity called as squamous cell CA, which 5 years back everybody was saying this mutation do not occur in squamous cell CA. You don't need to do, because the chances of it coming positive are very less. But I have one patient, I have actually 2-3 patients, where patient is having squamous cell carcinoma. I started on a regular chemotherapy because that time the notion was squamous cell will not have this kind of mutation, so chances are the patient will be losing money by doing all this test. But this patient progressed after first line of treatment. The treatment didn't respond, the chemo didn't respond, and then I did the complete panel, the NGS panel, when it was available, or at least the 12 gene panel. And to my surprise, my two squamous cell carcinoma patient were turned out to be EGFR mutated positive. And once I started this patient on second or third generation, for that matter, anti-EGFR treatment, they got an excellent response. So whatever earlier the thought process was that you should not do any mutation analysis in squamous cell lung cancer is now the guidelines has come that irrespective of histologies, at least some basic tests need to be done. And PDL1 has to be done irrespective of histology, whether it is adeno-CA or squamous. PDL1 is one expression where the immunotherapy works well, should be done in adeno as well as squamous cell. One more patient which was there, this patient presented with at very young age and presented with brain mets, directly presented with brain mets. Okay. Now, typically, this patient has to be tested for ALK. If someone present with brain mets, very small lung primary, no other distant metastasis that much, and you directly present with brain mets, these are the patient where you may get ALK positivity. Okay. And this ALK positivity are very, very poor responder to chemotherapy. Even if you give chemo, they will not respond. Anyway, chemo will not go to brain. So brain, you need to give RT to brain, and chemo will not reach to brain. So this patient deteriorates very, very fast. And if young patient present with brain mets, you have to do complete panel. Don't miss ALK status. This patient, I have one patient who is very young and turned out to be ALK positive. And eventually we could stop chemotherapy on this patient and started that patient on seritinib, because currently that time the third generation anti-ALK were not available in India. So these are the few real life instances where you should not take anything granted and you should do a complete genomic profiling, or at least the mini lung personalized genetic panel for all NSCLCs.
Right. Thank you, Dr. Bhushan, for elaborating a particular example, a couple of your clinical examples of the usage of personalized medicine. Thank you, Dr. Sushma, also for explaining to our audience what biomarker testing is and how is personalized medicine used. Dr. Somnath, my next question will be for you. I hope I'm audible to you. Yes. Yeah. So my next question is, while we talked with Dr. Sushma and Dr. Bhushan about personalized medicine and biomarker breakthroughs, I want you to shed light on some promising therapies and advanced treatments that you feel are currently under development for lung cancer in India, and how do you feel that this is going to impact, looking at 10 years from now? How do you feel that the prognosis is going to be improving? Please. Dr. Somnath, I hope I'm audible to you.
Yeah.
Yeah.
Hello.
I hope you were able to go through. You heard my question, right?
Yeah. So
Yes.
please repeat the question. There is some issue in network.
No problem. I hope I am audible now.
Please repeat the question.
Yes. So my question for you is, please shed some light on the upcoming promising therapies and treatments that are under development for lung cancer in India, and how do you feel that the prognosis 10 years from now is going to look like? Please. Dr. Somnath, we are not able to hear you.
There is
Say
lots
something.
of targetable mutation is coming, and lots of studies are there. Yeah. Now, am I audible?
Yes, sir. Please.
Yeah. So there is it is a very big answer. I have to give the big answer elaborately, but when there's plenty of time, shortage of time, and just giving brief some idea. There are several newer studies which are coming in this field of lung cancer advanced stage, like no uncommon mutation, mutation. There is several trials ongoing, and the the post TKI failure? What are the recent data of post TKI failure? Is there any of immunotherapy benefits in post TKI? That means patient is progressed on tyrosine kinase inhibitor, several, and then what are the next line? And another is HER2 directed therapies upcoming, and the top two directed therapy
Uh-huh.
like datodrama duloxetine, dato DXD, the tropion series is coming, and this year in presented in ASCO also the immunotherapy
Mhm.
plus dato DXD in top two directed advanced NSCLC, those who are driver mutation negative. And the
Right.
the PD-L1 negative population, role of recent update, and there is exon 14 skipping is another driver, that is upcoming data of post met exon 14 skipping inhibitor mutation, data of immunotherapy. These kind of things is coming. So it is evolving and rapidly changing day to day, and we have to see
Mhm.
the actually the group is like that in a basket: EGFR group, non-EGFR group, PDL1 high population, low population, and the all are negative population. So if we diversify these kind of things, it will be better to approach rather than a basket.
Right. Thank you, Dr. Somnath, for shedding light on the upcoming treatment protocols and how do you feel that the prognosis is going to improve. Dr. Sushma, my next question will be for you. Circling back to personalized medicine, for the layman, all the audience who has joined us, I want you to put some light on how do you feel biomarker testing facilitates the tailored treatment that we provide, and what benefits do you feel that this particular approach offers?
So basically, as we have already talked about it, biomarker testing, if we don't do it, then we have to blindly give treatment for adenocarcinoma, which is chemotherapy. On the other hand, if you do the biomarker testing, we know the various kinds of mutations which have been enumerated by Somnath and Dr. Bhushan. So, therefore, biomarker testing has become very essential to start personalized therapy, and it is become so important that, for example, that if I have some stories, very interesting stories where patients are surviving for 3 years on osimertinib. You can't even make out that the patient is suffering from cancer. They are leading such a normal life as compared to chemotherapy patients where they develop a weakness and hair loss and diminution even in quality of life.
Mhm.
Then I have another patient of ALK fusion who is on crizotinib, which is a drug which is being marketed by Pfizer. And it worked so well in him. He gained weight, and again, you cannot make out. He's taking that drug for the last 2.5 years. And so, therefore, biomarker testing is the most important thing which has to be done. There cannot be any treatment in lung cancer without that. So even if our patients has to wait for 1 more week where there has been delay, we tell them, look, if we start chemotherapy, you'll have a deterioration in your quality of life. So please wait, come back next Monday. Will be having the result, and hopefully, if it turns out positive, then you'll be spared of the side effect. So
Right.
therefore, this is so important. Is there
Right.
anything else you want me to tell?
Nah, thank you, Dr. Sushma. We'll circle back to you with the next question while we discuss further. Dr. Bhushan, my next question is for you. So while we have had your co-panelists get into depth about the importance of biomarkers and personalized medicines, my question to you will be: given your expertise, what recommendations do you have for your fellow healthcare professionals in India when they are trying to integrate personalized medicine and biomarker testing into their clinical practice, specifically for lung cancer patients? I'd like to hear your thoughts on that, please.
Yeah, so as Dr. Sushma rightly pointed out, without biomarker testing, as on today's date, we should not start treatment in lung cancer. Cost is an issue. Obviously, we can tackle that, but as EGFR treatment can be very cheaper. If you cannot afford third generation TKI, you can very well offer the first generation TKI if someone is not affording the EKI. Or for that matter, even in ALK positivity, if somebody is not affording lorlatinib, he can be very well offered with the first generation anti-ALK. But what is the bottom line is, without biomarker, without individualization, without precision medicine, a lung cancer treatment is not advisable as on today's date, even medico legally also. Coming back to the general public, actually, just to tell you the example, imagine that you are in a war, you are a soldier and you have two weapons with you. One is machine gun and another is a sniper. So machine gun is like, you just pull trigger, it will just fire 10 bullets,
Right.
and in 10 bullets it will kill normal people also, and
Right.
probably a enemy also. However,
Right.
sniper will not do like that. He will wait for a particular time, wait for a time to hit. So chances of damaging your own people with sniper is actually negligible, correct?
Right.
And that is what is thought process regarding this personalized medicine. You want to target a cancer cell, you don't want to target a normal cell. So this is all individualization, that you have to get the maximum effect with minimum most side effect. So that will be only possible if you have this genetic makeup tested of that particular individual.
Right. Thank you, Dr. Bhushan. Very nicely summed up. Very nice example that you got there. Dr. Sushma, my next question will be for you. Now, moving over to the last segment of this conversation, where we talk about patient education and we talk about a little bit awareness for everyone who is watching our session. Could be your fellow healthcare professionals, could be occupational therapists, or could be a general public. Now, as we know, COVID-19. How do you feel lung cancer and COVID-19, after COVID-19, the lung cancer care in India, and any preventive or any suggestions that you have for the general audience here, please?
Our suggestion is, first of all, to prevent getting into the smoking habits. And if one really can't, I mean, one has already got into a smoking habit, then one has to try their best to come out of it. And for this, I would like to urge all the smokers out there that it may sound like a Herculean task as to how to leave smoking, but believe me, we have seen it in our own family, and it takes only the willpower, and it can easily be done. So it's just a matter of a day. One should take a decision: tomorrow I'll not smoke, and then that's it. And then one does not have to turn back to smoking. So, and how to leave it? One is the willpower. Then there are certain tablets which are there which help you in coming out of that urge to smoke and take tobacco. There are some tobacco nil kind of tablets. So that is there. Post
Right.
COVID, I think now COVID is really gone. So it was only in 21 that this question was more valid.
Mhm.
So I actually I'm not in the pulmonology department, so maybe I would not be able to tell you the entire spectrum of these kind of patients post COVID
Mhm.
scenario, whether you when you if you confuse them with malignancy.
Mhm.
So this question, maybe I'm not the best to answer that. So is there anything else that you wanted me to shed light upon, Nishant?
Thank you, Dr. Sushma. That was it for this particular segment. Yeah, Dr. Bhushan, you would like to
Yeah, I just
add,
wanted
please.
to add two very important points which Madam pointed out. COVID, what did a COVID do? You will be surprised. There were more diagnosed CA lung cases in stage 1 and stage 2 in COVID era, for a very basic reason, because everybody was doing HRCT.
Yes.
So, if you really ask the thoracic surgeon, they would say that they have seen maximum number of stage 1, stage 2 lung cancer during COVID,
Hmm.
because patient used to do CHRCT for any for COVID reason, and they used to pick up a. I have two patients
Yes.
who were did a CT for COVID, and they were diagnosed with some small mass in lung, and incidentally diagnosed. They were not having symptoms of lung cancer. So that COVID had made, because we were doing rampant HRCTs in COVID, and then we could diagnose few lung cancer early. Coming to the smoking part of it, very well put by madam, that if you know, smoking is 30% cause of cancer across all the cancers. It's not only lung cancer. Smoking can
Yes.
cause 30% of cancer. So if you stop smoking, you will have 30% less chances of developing any cancer, I should say. Okay, and that's the only most preventable cause which is in our hand. So if you have never smoked, please don't start smoking. You have to quit smoking. If you have started smoking, stop as early as you can, because even if you have smoked for 20 years and आपको अगर ऐसा लगता है कि nothing is going to happen to me, believe me, a day will come. It's just a matter of one day to get diagnosed to have whatever particular problem. It doesn't only causes the cancer. It causes heart disease, stroke, and number of asthmas, COPDs. So I think smoking is the only thing which I will urge even to a government, that if they can stop smoking in by any way, or like they tried doing it 500 meters from school campus area, public smoking. Obviously, government is trying on their part, but smoking is one thing which is in our hand, and otherwise the genetic mutations are not in your hand. Believe me, it's the God, whatever God is responsible for that, or whatever it is. So what is in your hand, you have to do it, and in your hand only cessation of smoking is there. So you have to quit smoking. There is no second choice. There is no alternative to it, and you have to have that desire that I need to see smoking. Why it is difficult to smoke, quit smoking, is very, very important. If you have a alcohol habit, you to drink alcohol, you need to go find out some other place, you need to spend time. But smoking is very casual. It is sometimes thought to be a status symbol, which is very, very wrong. You can just go out of your building and smoke. So there is a smoking joint every 2 minutes walk, if you really see in a crowded place. So that is why it is a very dangerous habit to quit, because you have access everywhere. You get bidi, tobacco, whatever n number of tobacco products. So your determination that you have to quit smoking is the only way you can quit smoking. Doctor can only help you if you are fully determined to quit smoking. All these nicotine alternative chewing gum patches will only work if you are desired to quit smoking.
Right. Thank you,
One
Dr.
thing
Bhushan,
which
for please,
one
Dr.
thing which
Sushma.
got left out was the environmental pollution. Every day in the newspapers, we are seeing that the environment of Delhi is polluted, and the fireworks should be banned there. And the fireworks should be banned everywhere in India, because I don't think there is any part of India which is bereft of pollution. And in places where people are there in Delhi, for example, what should they do? At least they
Right.
should put masks. At least in this 1 month where the pollution is highest, they should wear masks and prevent themselves from getting the polluted smoke out there in the environment, because in non-smokers, that is the cause of cancer.
Right. Thank you, Dr. Sushma. So with this, we'll move over to the last particular section of this panel of discussion before we close it. So, Dr. Bhushan, I'll start with you. Firstly, to just like how Dr. Sushma just mentioned about particularly to a demographic, what could be some preventive measures for a better lung health? I'd like you to summarize such points for our audience here, for having a longevity of lung health and how to prevent. You just very rightly said that apart from smoking, nothing else is as such preventable. But a couple of environmental factors, a couple of lifestyle factors that you would like to summarize, please.
So there are preventive factors. First is smoking. You have to quit smoking. Second is pollution, as rightly pointed out. So try to reduce pollution. That is one thing you can do. And if you don't have any choice, at least wear a mask. At least try to at least try to prevent yourself. Third important thing: those workers who are working in some chemical industries, fumes or pneumoconiosis, there is some hazards pertaining to their profession. In that case, you have to wear the safety devices. So if you really go to some good company, they will always provide with safety devices to their worker. So cap, mask, if they are working in some lab, let's suppose somebody working in bio lab, so they need to wear the gowns, pillage gowns, mask, and whatever number of masks there are pertaining to whatever industry. So you can do that. You have to have your food habits also very good. You have to do yoga, meditation, deep breathing exercises. I'm not saying that deep breathing exercise will prevent having cancer, but that will increase your lung capacity, so that if you unfortunately have something, you will have better tolerance for that treatment. You will have better lung to get cope up with that treatment. You will have better result of the treatment. So these are few factors. Also, if your family history is very strong of any cancer, I'm not particularly talking about lung cancer, and if you're crossed some particular age, let's suppose in Western world, if a particular age is crossed, it is a government responsibility to search to test their people, to test their population. In India, it is not possible because of sheer population. We cannot blame government. We can take care of ourselves. So if you have crossed your age of more than 35, or I should say in India at least 45, you can get chest X-ray, sonography, in females mammography, pap smear, in males prostate specific antigen. So commonest cancer. I would not say that this test will prevent you from having any cancer, but at least you can diagnose the cancer early, and if you can diagnose the cancer early, you can treat it very well.
Right. Right. Thank you, Dr. Bhushan. Dr. Sushma, my question to you before we move over to the last segment of this discussion is: any myths or misinformations or misconceptions about lung cancer that you have seen in your clinical practice for over 2 decades that you would like to bust through the medium of this awareness talk, please?
So one of the myths that the patient says कि biopsy कराने से हमारा बीमारी बढ़ जाएगा. So this is very irritating. So I said कि अगर biopsy से तुम्हारा कैंसर बढ़ता तो फिर हम यहाँ पे बैठे गलत एडवाइस आपको थोड़ी ना देंगे.
Correct.
So therefore, a biopsy has to be done. Otherwise, all this story of personalized medicine cannot even start. So biopsy does not cause a rampant increase in the growth of cancer. First of all, this is most important myth that I usually keep coming in daily in my clinic. Then otherwise, the other thing is that anti-tubercular treatment, it is not a myth. It should only be started if the patient has a sputum or blood test positive for tuberculosis. So these two are the most important thing. The other third thing that lifestyle factors you said was that one has to be really be fit, and obese patients are more liable for developing most cancers, not in lung. But obese patients also have a poor tolerance to therapy. So therefore, obesity, one should avoid it at any cost, because apart from cancer, obesity is also the cause of heart diseases. So if the patient doesn't have, if the patient has lung cancer and is obese and has heart diseases, then his tolerance to the treatment is poor. So this is very one important risk factor around the globe, that one should avoid developing obese, because once you get so much of fat, it's very difficult to shed it. So best not get it. Be on the lookout always that you should not have a poor BMI. You should always have a healthy BMI. So
Right.
these are the important things that comes to my mind now.
Thank you, Dr. Sushma. So with this, we'd like to bring this particular panel of discussion to the last segment. Dr. Bhushan, I'll start with you. Give a key take-home message for all the viewers, all the fellow healthcare professionals, all the patients, maybe caregivers who have joined this particular session, please.
Yeah, just before giving a message, I wanted to two important myths, because that is very commonly everybody talk about. First is cancer communicable? Many times, like family members say that my mother is having cancer. If we eat together, if we share the same room, if we sleep together, if husband wife sleep together, do I have a chances to get cancer? So believe me, only good thing about cancer in late stage is that it is not communicable. So it will not get transmitted from one people to another. TB may get. Okay. So you have to be very, very positive, and you have to be very, very supportive to your family. Don't worry. You have to support to your family. Believe me, no cancer is yet reported to be a communicable disease. Like no cancer. Forget about lung cancer. None of the cancer. Second important myth, which always a concern, I should say, not a myth, that I am having cancer. Do my kids are prone to get cancer? If I am having lung cancer, मेरे बेटे या बेटी को होगा क्या? So lung cancer is not hereditary. If you really ask me, there are some cancer which are hereditary. There are I should not say that every cancer is not hereditary. Some breast cancer, some colon cancer, some prostate cancer can hereditary, but lung cancer are not hereditary. So if your father or mother is having cancer, it doesn't mean that you are going to have cancer. Okay, so this is very important point. As a general public, you should know that if some family member is having cancer, doesn't mean that you are also going to have cancer.
Right.
Now the main takeaway which I wanted to give to people is stop smoking, get yourself tested. Whatever alarming symptoms we have discussed in this online seminar, if you have anything of this, please see your doctor. I am not saying that directly see to oncologist. Go to oncologist. You see your routine general physician, general practitioner, and they do get yourself tested and go to the cause of whatever you are having problem, whether it is TB, asthma, bronchitis, cancer. But please get yourself tested, and if you get tested and if turn out to be positive, don't lose your hope. We are way ahead with whatever we were doing few years back. Believe me, earlier stage 4 cancer is like we were doing nothing. Now we are getting, I should not say for lung cancer, for melanoma, even in stage 4 cancer, there are 20% long-term survival. And that's the beauty of these new medicines, immunotherapy, targeted therapy. So even if you have stage 4 cancer, if you are at the right genetic makeup, if your causation of that cancer is by God grace is a right genetic alteration has happened to you, you can get a very long-term survivor. Or even for that matter, in some cancer, even in stage 4, we can use word as a cure. I am not saying it is for lung cancer, but for some cancer. Okay, so this is to be there for all general viewer, general online viewer and listener, and for even a healthcare professional. I would say, if you are getting some patient of cough and is not getting managed, please consider oncology, at least in elderly patient or in a smoker, as your differential diagnosis for that particular problem.
Right. Thank you, Dr. Bhushan, for very nicely summarizing the message. Dr. Sushma, your key take home for all the audience who has joined us, please.
So my key take home is that quit smoking, and the other is that if you are a smoker and you have been started by your physician on anti-tubercular treatment, please recheck it for the positivity. Otherwise, you could be having a lurking cancer, and those 3 months are very pivotal in your treatment being started late. So, and apart from that, if at all any family member is diagnosed, go ahead for a proper biopsy and personalized therapy. And don't lose hope. Even the company, corporate sector is out there to help the patients. They provide patient support program. For example, the Pfizer, which is holding the meeting today after 1 year of therapy, Crizal, they offer free treatment. That's a big thing. You spend 5-6 lakhs, and beyond that, if your that drug is working on you, the company gives these kind of benefits. So the benefits are many, plenty rather, and therefore one should not lose heart after all if they or their family member develop cancer.
Right. Thank you, Dr. Sushma, for that wonderful message. So with this, I'd like to bring this particular panel to a closure. Firstly, I'd like to thank Pfizer for powering this panel. Secondly, I'd like to thank my panelists, Dr. Sushma, Dr. Somnath, Dr. Bhushan. Thank you for taking time out of your schedules, stepping up with Voice of Healthcare and creating awareness about lung cancer. And lastly, I'd like to thank all the viewers who have engaged with us, who have been a part of this particular panel. To each one of you, thank you. Thank you for stepping up. Thank you for creating awareness, and have a good evening. Thank you.
Thank you.
Thank you,
Happy Diwali to
Nishant,
everyone.
and happy Diwali. And don't light crackers and avoid atmospheric pollution. That is my utmost, very sincere request to all who are watching this. Thank you and bye.
Happy Diwali to both of you as well.
Happy
Thank
Diwali.
you.